conjunctival injection. The second part, it is deep or pericorneal injection. It is near the cornea, near the limbus, and more deep and deeper. The third one is mixed injection. It is pericorneal plus conjunctival. Fourth one is superficial corneal vascularization, when the vessels goes from the conjunctiva to cornea. I will remember you that in the cornea we don't have vessels at all, and when there is inflammation, the vessels can grow to the cornea. It is superficial vascularization. Also can be the deep vascularization of the cornea in the deeper layers of the cornea. It's the fifth one, and the sixth one is a mixed corneal vascularization, deeper and superficial. First of all, we will speak about the pathological processes in eyelids. And the first pathological process is inflammatory disease of the edges of the eyelids. It is blepharitis. Blepharitis can be acute and can be chronic. Factors that induce chronic inflammation are refractive errors. It can be the problems with, such as hypermetropia or astigmatism. Also, it is dry eye syndrome, chronic conjunctivitis, diseases of the gastrointestinal tract, or endocrine system. Also can be the impact of allergens, dust, dry air, smoke. Here we see the normal eyelid, and here there is an inflammation, blepharitis. There are different clinical forms of blepharitis. First of all, there's simple blepharitis, then is seborrheic, ulcerative, marginal or posterior, and demodex blepharitis. We will speak one by one about all of them. First of all, simple blepharitis. During the simple blepharitis, there are such complaints as burning, itching, eyelid heaviness, rapid eye fatigue. Objective symptoms are hyperemic and thickened edges of the eyelids and bilateral process. Very rare there is a one-eye blepharitis. Blepharitis mostly is bilateral. Bilateral, yes. Simple blepharitis is often combined with chronic conjunctivitis, and in some cases combined with marginal keratitis. Treatment: daily hygiene procedures, and 1-2 times a day on the edges of the eyelids apply hydrocortisone ointment. It is corticosteroid. Course can be up to 2 or 3 weeks. Also, we can use solutions of antiseptic or antibiotic instilled into the conjunctival sac, and anti-allergic treatment. Sorry. The next blepharitis is seborrheic or scaly blepharitis. Complaints are burning, itching, heaviness, the same as in the first one. What can we see extra in extra symptoms? It is a large number of small scales on the skin of the eyelid and eyelashes, like dandruff. Also, it is bilateral process. I mean these scales. Scaly blepharitis is often combined with chronic conjunctivitis, also can combine with marginal keratitis, the same as simple blepharitis. Here we need as a treatment, we need also the daily hygiene procedures, application of alkaline solutions to soft to the scales, followed by cleaning the edges of the eyelids. In addition, we can use also corticosteroid ointment up to 2 or 3 weeks, and antiseptic or antibiotic eye drops to the conjunctival sac. Also, the next one is ulcerative or staphylococcal blepharitis. It is the most persistent and severe form of inflammation of the eyelids. Symptoms are the formation of purulent crusts, ulceration on the skin of the eyelids, edges, and shortening and fragility of the eyelashes, scarring of the eyelid edge as a result, improper growth, graying, or loss of eyelashes. What about treatment? As in the two first ones, it is hygienic procedures. Also, ointment with antibiotic, not corticosteroid. Antibiotic we need here. It can be tetracycline or erythromycin or fluoxetine ointments. It is ointment, eye ointment, of course. Also, we can use combined ointment, antibiotic with corticosteroids, but this kind of ointment we need when the ulcers will close. The local use of eye drops with an antibiotics is possible too. Posterior or marginal blepharitis. It can be named dysfunction of the meibomian glands. Symptoms: local or diffuse inflammatory reaction, redness and thickening of the eyelid edges, formation of the telangiectasias in the blocked openings of the meibomian glands, the hyper or hypersecretion, accumulation of yellowish-gray foam or secretion in the outer corners of the eyelid and the posterior eyelid rib, hyperemia of the palpebral conjunctiva, disorder of the precorneal tear film. We spoke about the meibomian glands and their openings near at the edges of the eyelids. Here we can see the openings of the meibomian glands with the secretion, with the very it is pathological secretion of the meibomian glands. When squeezing the edge of the eyelid between the fingers and the glass rod, thick or foamy secret comes out of the meibomian glands. So we can use our finger and sterile stick, glass stick, and squeeze the eyelids, so we see this kind of secretion. In addition to the above treatment, medical massage of the eyelids with a glass stick is used. So it is a picture with medical massage of the eyelids. Demodex blepharitis is caused by the saprophytic mite demodex. Also, I want to say that demodex may be the cause of simple or squamous blepharitis and may be combined with other causal factors. Symptoms here are redness and thickening of the eyelids, the presence of scales, crusts, white clutches on the eyelids. It's a specific symptom in demodex blepharitis, white clutches at the eyelashes. The mite settles in the opening of the meibomian glands and in the ciliated follicles. The main complaint is itching of the eyelid area here. Also redness and swelling. Oh, only 26 students. I know that you can use one telephone or one computer for several students, but only 26. It's very small. It's too small. Okay, demodex blepharitis. The next slide. Demodex blepharitis. For diagnosis, we need to remove 5 eyelashes from each eyelid and look them under the microscope. The diagnosis is confirmed by detection of larvae around the root of the lashes and 6 or more movable mites. It's a demodex mite. In the treatment, in addition to the above methods, specifically anti-demodicosis creams and gels should be used. For example, blephar gels is a second, ointment with ichthyol, demolam, etc. The next kind of inflammation in the eyelids is stye or hordeolum. It is acute purulent inflammation in the hair sac, meibomian or other glands at the root of the lashes. Etiology, it can be caused by pathogenic microorganisms, Staphylococcus aureus, Streptococcus. The emergence of hordeolum is often associated with general diseases, hypothermia, dental diseases,
Да,
gastrointestinal tract. What can you ask? It was mistake of hand in the chat. Okay. Also, hordeolum can be associated with hypo and avitaminosis, uncorrected refractive errors, and diabetes. Symptoms along the edges of the eyelids. There is a limited painful swelling. The skin in the area is hyperemic, edematous, and the conjunctiva too. After 2 or 3 days in the place, pustule is formed, around which still persists hyperemia and swelling. After 3-4 days, the abscess is opened and cured. Attention please, the extrusion of hordeolum is absolutely unacceptable. It cannot be used in treatment of hordeolum. And what about treatment? Installation of 20% solution of sulfacetamide or solution of antibiotics from 6 to 8 times a day for 7 or 10 days. Ointments with an antibiotic on the skin of the eyelid or in the conjunctival cavity. We choose one of the ways to the skin or to the conjunctival cavity due to the variant of hordeolum. It can be outer one or inner one. So due to it, we use skin or conjunctival variant of ointment usage. Also, we can use dry heat, but it must be very careful. Not each case need to use dry heat. Also, ultra high frequency therapy can be used. Also, antibiotics or sulfonylamides are prescribed orally. If we have the situation with recurrent hordeolum, we need to make the general examination of the patient because it means that there is some immune suppression of the organism. Chalazion is the next variant of inflammation in the eyelids. Chalazion or meibomian cyst is an inflammatory cyst usually due to a blocked meibomian gland. It is a denser structure than hordeolum. The skin over it moves easily. Its color is not changed. If recurrent growing chalazion requires different diagnosis with adenocarcinoma of meibomian gland. If a lesion requires in the same place 1, 2, 3 once, yes, it can be adenocarcinoma. Because of it, we need to use surgery treatment and make the histological diagnosis. Um, in the treatment of lesion, in the initial stage of the local injection of quinolone, we can use corticosteroids injections into the capsule of lesion. It can be used, but only in initial stage. Also, we can use dexamethasone or proteolytic enzymes. But the most radical and most useful is surgical treatment, here on the picture. The next part of the lecture goes to the conjunctiva and diseases of conjunctiva. Conjunctivitis. Conjunctivitis is an inflammatory reaction of the conjunctiva to various effects. They divide into chronic and acute, and also to infectional and allergic. The common characteristics are hyperemia and edema of the mucous membrane, edema and itching of the eyelids, discharge from the conjunctiva, the formation of follicles on palpebral conjunctiva, or it may be not follicles but papillae on it. Sometimes accompanied by a lesion of the cornea with visual impairment. And the variants of conjunctivitis. Bacterial ones are simple bacterial conjunctivitis, gonococcal keratoconjunctivitis, and conjunctivitis of Koch-Weeks. Viral conjunctivitis, adenoviral ones, and herpes simplex conjunctivitis. And chlamydial ones, it's chlamydial conjunctivitis of adults, it's paratrachoma and trachoma. And first of all, simple acute bacterial conjunctivitis. The most common etiology is Staphylococcus. Acute conjunctivitis often occurs in children. Usually, the pathogen enters the eye from the hands. First, one eye is affected. Then, after 2-3 days, the other one is affected. Complaints are discharge on the eyelids, itching, burning, and photophobia. Clinical manifestation of acute conjunctivitis are hyperemia and edema of the conjunctiva of the eyelids, transitional folds, and sclera, mucopurulent and purulent discharge. In the morning, the patient hardly opens their eyes, and as the eyelids stick together. Something goes wrong. One second. Maybe there is a problem with the internet. Oh, the picture is opened. Chronic bacterial conjunctivitis. It develops slowly, proceeds with periods of improvement. Complaints are photophobia, mild irritation, and rapid fatigue of the eyes. Symptoms are conjunctiva is rather hyperemic, loosened. Along the edges of the eyelids there may be crusts. Conjunctivitis may be associated with nasopharyngeal diseases, otitis media, sinusitis. In adults, conjunctivitis often occurs in chronic blepharitis, dry eye syndrome, lesions of the tear ducts. A separate form of chronic conjunctivitis is angular conjunctivitis caused by the Moraxella Axenfeld or diplobacillary conjunctivitis. This conjunctivitis is sorry, is characterized by a white foamy discharge in the outer corners of the eye. Here. Maturation of the skin in the corners of the eye. In treatment, it is necessary to use zinc drops or eye drops with zinc. The next variant of conjunctivitis is the gonococcal conjunctivitis of newborns. It's rather heavy disease and typically occurs during passage through a birth channel. It is a bilateral process. There is hemosis and eyelid swelling. Can extend deeper and leads to corneal alterations, scarring, deformation, and visual impairment. Um, Also may have systemic manifestations. As treatment, we need antibiotics, topical ones, and also intravenously or intramuscularly ceftriaxone. Signs of gonococcal keratoconjunctivitis are it is acute, profuse, purulent discharge, and hyperemia and hemosis of conjunctiva. And there are complications. It is corneal ulceration, perforation, and endophthalmitis if severe. Endophthalmitis, it is an infection into the eye, inside the eye, and it is a disophiable. Treatment. Here we need topical antibiotics such as gentamicin, cipralead, and of course we need intravenous or intramuscular antibiotics. To detect bacterial infections, microscopic examination of smears from the conjunctiva and cultures are used. The isolated microflora is examined for pathogenicity and sensitivity to antibiotics. But treatment we start mostly before taking the results of microscopic examination, because microscopic examination of smears give us the answer only in 7 days, but we need to treat in the first, second days from started the conjunctivitis. About the general treatment of all types of bacterial conjunctivitis, we need antiseptic drops or eye drops of with antibiotics. It can be tobramycin, levofloxacin, 4 times a day or more if it is needed during 7 or 10 days. Eye ointment with an antibiotic, it can be tetracycline or fluoxetine 2 or 3 times a day. Also, it can be used during the 7 or 10 days. With edema and pronounced irritation of the conjunctiva, installations of non-steroidal anti-inflammatory drops are used. For example, diclofenac, nepofenac. It can be used 3 times a day during 10 or more days if it is needed. Now about the viral conjunctivitis, and the most common one, it is adenoviral conjunctivitis. It can be 2 types, pharyngoconjunctival fever and epidemic keratoconjunctivitis. About the first one, pharyngoconjunctival fever, it is can be caused by third or seventh type of adenovirus. Typically affects children. Upper respiratory tract infection can be with conjunctivitis together, and in 30 persons it can be keratitis. About epidemic keratoconjunctivitis, types of adenovirus are 8 and 19. It is very contagious and no systemic symptoms. And keratitis can be caused in 80% of cases. And firstly, about epidemic keratoconjunctivitis. It is the second one. Um, Modes of transition are contact and airborne. The incubation period lasts 4 or 7 days, but now last years, we can say that incubation period is more than 10 days, 10 till 14 days. Complaints are cutting, feeling of a foreign body in the eye, lacrimation. The onset of the disease is acute. Both eyes are affected at intervals of 1, 2, or 3 days. Clinical picture contains edema, hyperemia of eyelids, edema and hyperemia of conjunctiva of the eyelids, and transitional folds. In the lower transitional fold appear spot hemorrhages of the and follicles. After 5 or 7 days, spot subepithelial infiltrates appear on the cornea, and dense fibrous film can be formed on the surface of the tarsal conjunctiva. Here we can see this one on the upper eyelid, and we need to remove this fibrous film with tweezers. Of course, it can be on the upper eyelid or in the inner or in the on both eyelids, of course. The pharyngoconjunctival fear is The pharyngoconjunctival fear usually occurs in children. It is Its incubation period lasts from 3 to 10 days, usually 5-7 days, not more. The duration of adenoid conjunctivitis is 2 weeks, and sometimes this period is a little bit more than 2 weeks, from 2 to 3 weeks. The symptoms of the disease are similar to the initial clinical manifestation of epidemic conjunctivitis, but their intensity is much lower. And of course, both eyes have this illness, but the first eye is rather more than the second eye. On the cornea, point epithelial infiltrates may appear, but they disappear without a trace, without affecting visual acuity. Common symptoms: defeat of the respiratory tract with an increase in body temperature and headache. Systemic damage may precede eye disease. Treatment. Treatment is difficult because there are no drugs that selectively affect adenoviruses. Common antiviral drugs can be used at interferons or interferon inducers 6 or 8 times a day during the 10 and more days due to the variant of adenoviral conjunctivitis. In the acute period, non-steroidal anti-inflammatory eye drops are instilled 3 times a day, and antihistamines are taken orally for 5 or more days, from 5 to 10 days, with a tendency to form films enduring corneal infiltrates. Corticosteroids, such as dexamethasone eye drops, are prescribed according to a decreasing scheme. In corneal lesions, corneal protectors are used. In cases of lack of lacrimal fluid for a long period of time, artificial tears are used. In these pictures, you can see those spots on these infiltrates or spots on the cornea, and they can cause the lesion of the vision. About the prevention of nosocomial adenovirus infection, we need to make the examination of the eyes of each patient on the day of hospitalization to prevent the introduction of infection into the hospital, or the detection of cases of diseases in the hospital. isolation of patients in single cases of the diseases, and quarantine in outbreaks, anti-epidemic measures, sanitary and educational work. What can I say a little bit more about the adenoviral conjunctivitis? Here, maybe stop. Yes, all of us know about the coronavirus, and coronavirus can cause the conjunctivitis too. And now we have some knowledge about this variant of conjunctivitis, and it is similar to adenoviral conjunctivitis in the form of pharyngoconjunctival fever. It have the coronavirus infection can start with conjunctivitis too, and it is something like the adenoviral conjunctivitis, and the treatment is similar. Um, the next one of viral conjunctivitis is epidemic hemorrhagic conjunctivitis. It is little bit similar with epidemic conjunctivitis adenoviral caused by adenovirus, but there is another etiology. It is enterovirus 70, and the incubation period is very short, 12 or 48 hours. Transmission of the pathogen is contact. This variant of conjunctivitis is very contagious, and in eye hospitals, from 80 to 90% of patients may be affected in the absence of the anti-epidemic measures. It is very contagious. The onset of the disease is acute. First of the eye is affected after 8 or 24 hours, the second. Complaints are severe pain and photophobia. Also, in this variant of conjunctivitis can be fibrous films on the conjunctival folds. Symptoms of epidemic hemorrhagic conjunctivitis are discharge is mucous or mucopurulent. Conjunctiva is sharply hyperemic, especially subconjunctival hemorrhages, such as here. Changes in the cornea are minor. Point epithelial infiltrates can be very small. Treatment consists in the use of antiviral eye drops, interferon inducers, in combination with anti-inflammatory drugs, first anti-allergic, and from the second week corticosteroids. The duration of treatment is from 9 to 14 days. Recovery is usually without consequences. So we have a lot of problems during the disease, but after that we don't have any problems after the finishing of it. And the next part of the lecture is chlamydial eye diseases. Chlamydia or Chlamydia trachomatis is an independent type of microorganism. It is intracellular parasites, inhibit the properties of both viruses and bacteria. Different serotypes of chlamydia cause different conjunctivitis disease. Trachoma is due to serotypes from A to C, and chlamydial conjunctivitis of adults and newborns serotypes from D to K. Trachoma is chronic infectious keratoconjunctivitis characterized by the appearance of follicles and papillae on the conjunctiva, followed by scarring inflammation of the cornea named panis. And in the later stages, eyelid deformation. The incubation period is from 7 to 14 days. Eye damage is usually bilateral. In the clinical course, the trachoma, there are 4 stages. The first stage In this stage, there is an acute increase in inflammatory reaction, diffuse infiltration, edema of the conjunctiva with the development of single follicles in it, which have the form of cloudy gray grains located randomly and deeply. There are very big follicles on the upper eyelid on the conjunctiva, very, very big follicles. Um, the formation of follicles on the tartar conjunctiva of the upper eyelid is characterized. Uh, Only some kind of conjunctivitis have this kind of follicles. It's chlamydial diseases and it is allergic disease. In stage 2. In stage 2, against a backdrop of increasing infiltration, the development of follicles starts the decay. Scars are formed. In conjunctiva, there is no follicles at all, but the scars are formed, express the defeat of the cornea. In the stage 3, the process of scarring is dominated, and there are a lot of scars and problems in the upper lid conjunctiva. In the formation of it is the formation of scars on the conjunctiva that makes it possible to distinguish the trachoma from chlamydial conjunctivitis and other follicular conjunctivitis. It is the scars after the follicles. It is the uh, variant only of trachoma disease. And the fourth stage is the last stage of trachoma. In the stage 4, there is a spill scarring of the affected mucosa. In the absence of inflammatory phenomena in the conjunctiva and cornea, there are only scars, but there is no inflammation yet. And in this stage, we can see the penis. It is inflammation with vessels growing into it, into the cornea, extended to the upper segment of the cornea. Because all problems with conjunctiva goes to the upper eyelid and conjunctiva of the upper eyelid. Because of it, the cornea is affected on the upper part too, and we see the growing of the superficial growing of the vessels from the conjunctiva to the cornea. Penis is characteristic feature of the trachoma and is important in differential diagnosis of this disease. In the period of scarring on the site of penis, intense opacity is formed in the upper half of the cornea. Here is the opacity of the cornea. Complications of trachoma. Complications of trachoma is joining the infection, dacryocystitis cystitis and canaliculitis, trichiasis, symblepharon. Symblepharon, it is here on this picture where we have, I'm sorry, please 1 second. Now you have 5 minutes to put your names in the chat. I put here start, and you have 5 minutes to put your names. I'm sorry again, and after I will put their stop in the chat. I will not take your names. So you have 3 minutes more. I will what I told you about the symblepharon. Yes, symblepharon. Symblepharon is in this picture, where the conjunctiva of the eyelid grows to the cornea and have this kind of deformation. The next complication is deep parenchymal xerosis, and xerosis is here. It is xerosis of the cornea and eyelid inversion. Treatment of trachoma. Antibiotics, drops of fluoroquinolones, tetracycline ointment, which are used from several weeks to several months. It's not the mistake. In the case of trachoma, the antibiotics of fluoroquinolones can use for weeks or months. Trichiasis and entropion are eliminated surgically. The prognosis with timely treatment is favorable. There may be recurrences, so after the course of treatment, the patient should be under observation for a long time period. The next theme is chlamydial conjunctivitis of adults, or paratrachoma. Paratrachoma, it is infection occurs as a result of transfer of infection from the genitals. Symptoms: severe edema of the eyelids and narrowing of the eyelid, severe hyperemia, edema and infiltration of the tarsal conjunctiva, and transition folds. It is especially characterized by large loose follicles located in the lower transitional fold. And further merging in the form of 2-3 rollers. For example, here 1, 2, 3, and here 2. Discharges mucus first and then become abundant purulent. You have 1 minute, and then I will put stop and stop your checking. Chlamydial conjunctivitis often in chlamydial conjunctivitis, often there are changes in the cornea in forms of the subepithelial or epithelial point keratitis or inflammation in the lip or pseudopanus. Here it's pseudopanus. Much less often there are small marginal abscesses. From the 3rd or 5th day of the disease, original parotid lymph nodes are involved in the process, but their palpation is painless. The duration of acute chlamydial conjunctivitis is from 2 or 3 weeks to 2-3 months. It's very long too. Okay, I think it is. Hybrid stop. I think. We stop the checking of your presence, but we don't stop the lecture. There is Sharon Kutipilavil. You up your hand. What do you want to ask or nothing? Видимо, nothing. About treatment. Also, we use eye drops of fluoroquinolones here on decreased skin for 5 weeks. Antibiotic therapy orally too. Additional therapy includes anti-inflammatory drops, antihistamines for 5 days. 2 weeks prescribed eye drops, dexamethasone, 1 time a day. The next part of diseases of the conjunctiva is degenerative diseases. There is two variants of degenerative diseases which you need to know. It is pinguiculum. It is associated with ultraviolet exposure and chronic dryness, and it is abnormal growth of conjunctiva. And the next one is pterygium. Pterygium associated also with ultraviolet exposure, chronic dryness. It is abnormal growth of the conjunctiva onto the cornea. It destroys the Bowman's membrane of the cornea, and there is a specific line, it's Stoker's line. It is iron deposit along the leading edge of the pterygium. It can block vision and causes irregular astigmatism. Pinguicula and pterygium. The main difference between them that the pinguicula doesn't go to the cornea. It is pathological growth of the conjunctiva in one point. But the pterygium, it is a pathological growth of the conjunctiva to the cornea. It's the main difference between pinguicula and pterygium. So it's not inflammatory diseases. It is dystrophic diseases. What about sclera? Sclera, it's not the additional apparatus of the eye. It's not auxiliary apparatus of the eye. But when we speak about the inflammatory diseases of conjunctiva, we cannot stop telling about the sclera, because the inflammation can start in the conjunctiva and then goes to the sclera. I will remember you a little bit about the sclera. It is a posterior 5/6 of the eyeball. It is a fibrous tissue, and it is a fibrous layer of the eyeball. It is opaque appearance and a less uniform orientation of collagen fibers. The vessels in the cornea can show us the inflammation, and here we see 3 variants of here can you see in the scheme the mucous tissue, it is conjunctiva, but there are vessels under the conjunctiva in the sclera, and in normal eye we can see them, but they are not white and not inflamed. There are 2 variants of inflammation in the sclera. It is episcleritis, it's superficial part of the sclera, and scleritis, it's more deeper part of vessels of the sclera. Again, sorry, there is internet problems. I'm sorry, I need to wait for my internet. Yes, sclera, normal, yes, episcleritis. Episcleritis can be in 2 forms. It is simple episcleritis, it's nearby 80%, and nodular episcleritis, it's nearby 20%. Episcleritis, it is inflammatory disease of the sclera. Inflammation of episcleral tissue between recti muscular insertion and limbus. Episcleral edema without scleral edema. It is superficial inflammation. Sudden onset with localized injection and swelling in intrapalpebral region. It is unilateral. It was only on the one arm in two-third cases. Cause is unknown, maybe a hypersensitivity reaction. Um, Also, it can be the reaction on some chronic diseases in the human organism. It can be caused in men, so women in the age of 20 to 50 years old. It is in the form. It is in the form of transient attacks. Uh, If the episcleritis was caused in one arm, in 60% it can be recurrent in the either arm. What about treatment? We can use topical vasoconstrictors. It is eye drops with vasoconstrictors. Also non-steroidal anti-inflammatory drugs in eye drops also, and corticosteroids. If we speak about the oral medicines, it can be non-steroidal anti-inflammatory drugs. About the scleritis. Scleritis, it is intense, dull, radiating pain and insidious onset. It is bilateral and recurrent. In the case of scleritis, can be keratitis in the 50% visit. Also, it can be iridocyclitis with scleritis in the 50%. Also, we can find vitritis, secondary glaucoma, cataract, macular edema, and choroidal attachment. And there are so many diseases which can be with scleritis because of the mechanism of this disease. It is immune-mediated vasculitis. And it leads to a destruction of the sclera. One third of scleritis is diffuse nodular scleritis, and two-thirds is necrotizing scleritis associated with systemic diseases. The most common rheumatoid arthritis. There are a lot of diseases of our organism which can cause the scleritis, and there is a big table of them. They can be autoimmune diseases, and the most of autoimmune diseases can cause the scleritis. Also, it can be oncodiseases. But there is a line unknown. There are unknown causes of the scleritis. And what about treatment? The treatment of scleritis. We need to define all the underlying disease, of course, and start to treat it. Because of it, if we see the scleritis first one or recurrent, of course, if recurrent, we need to we need to send this patient to the therapist or to the rheumatologist because we need to find the underlying disease. Topically, we use antibiotics, non-steroidal anti-inflammatory drugs, and corticosteroids. And the same ones we need to use systemic, orally or intramuscular injections. Also, we need to use immunosuppressive agents, but this treatment we cannot use only as ophthalmologist. We need to use it together with therapeutics or with rheumatologists. The next part of the lecture It is about pathology of the lacrimal organs. What about lacrimal organs? Uh, they produce and remove tears into the nasal cavity. Lacrimal organs are the lacrimal gland, big gland. There are additional small lacrimal glands in the conjunctival folds and ducts. Tear ducts. In the lacrimal lake is here, in the medial corner of the eye. In the lower and upper lacrimal, from the lacrimal lake, the lower and upper lacrimal points there are here, and from which the lower and upper lacrimal canalically goes, here canalically, goes to the lacrimal sac. It is lacrimal sac. The nasolacrimal duct goes from the lacrimal sac to the nose and opens under the anterior end of the lower nasal cone. So the tear products in the and small lacrimal glands then goes to the lacrimal lake, lacrimal canaliculus, lacrimal sac, and nasal lacrimal duct, and goes to the nose. The main lacrimal gland, big one, actively functions only in conditions of emotional outbursts and irritation of sensitivity nerve endings, and everyday tears are produces in the little small lacrimal glands which there are in the conjunctival folds. It was about anatomy, and now about the pathology. Pathology of lacrimal organs. And first of all, it is acute dacryoadenitis. Dacryoadenitis, it is acute inflammation of the lacrimal gland. Complaints are severe swelling, soreness, hyperemia of the outer part of the upper eyelid. This one. Clinically, objectively, we see the hyperemia and edema of the conjunctiva of the eyeball in the upper outer part. The displacement of the eye downwards and inwards, limiting its mobility because of the swelling of the lacrimal gland. Etiology, it can be a complication of common infectious influenza, angina, measles, scarlet fever, typhoid fever, etc. Often occurs with parotitis. Treatment. Sometimes we use dry heat. Also, we need ultra high frequency therapy, sulfonamides orally, intramuscular injections of antibiotics. When separation, an incision is made with subsequent drainage of the abscess and the imposition of hypertensive bandages. So it is severe disease. If it is acute, it can be very severe disease, and also it can be not in the adults but in children too. Dacryocystitis. Dacryocystitis, it is inflammation of the lacrimal sac. Dacryoadenitis, it is inflammation of lacrimal gland, main lacrimal gland, and dacryocystitis, it is inflammation of lacrimal sac. It can occur in an acute form and chronic form.